Hello, everybody. This is 20 years old female patient presenting with abdominal pain, vomiting, low-grade fever since 1 month. Upper endoscopy revealed a duodenal ulcer with necrotic floor. Biopsies revealed duodenitis. Ultrasound revealed multiple abdominal lymphadenopathy. Her CBC, liver, kidney functions were all normal. Her ESR even is not so elevated. So we are doing now EUS and FNA if possible with Dr. Paulo and Dr. Jensberg.
Hello everybody. Here we are again
You loud and clear?
for this morning. I have my good friend and fellow here.
Good morning.
Good morning, everybody. So we start the procedure from the second part of the duodenum. When I was going in with the instrument, we have seen a lot of residual of food inside the lumen. So we go into the second part of the duodenum to detect if there is any gastric outlet obstruction, but we didn't find any of them. So we are now in the second part of the duodenum, and we can have a look of the pancreatic head here of this young lady. So the pancreas seems to be really normal, but when I go up and turn my instrument up to look to the hilum of the liver, you see here that a clear big mass, the lymph node mass is coming. So
When do we freeze and we'll
Yeah.
take a measurement?
we can have some
Perhaps
evidence of this.
you could just discuss briefly what the differential diagnosis would be for a diffuse adenopathy in a relatively young woman
I think that
with otherwise absence of symptoms. She has
Yeah.
abdominal pain, but no weight loss, maybe low-grade fever.
Yeah. This could be a very interesting case because the differential diagnosis in this case could be lymphoma, or
look to the
could be
camera.
some. We can have some problems of infection in this region. Could be TB, but as I already told you yesterday, the TB appearance usually the lymph nodes in TB have an appearance which is clearly different as in the lymphoma.
And how are they different?
Yeah, because you know that there is necrotic necrosis, and the caseosis necrosis is bright. So I am expecting to have whitish appearance of this lymph node if I am expecting to have a TB inside this lymph node.
Are there diagnoses local to Egypt that we should be thinking about that we haven't considered?
I don't know if this patient could be in Europe. I think that the main is lymphoma. The main.
I think also in this age, lymphoma is the commonest. There is some other causes of lymphadenopathy, but not this size, and it is not caseating or something. So I think the first possibility is lymphoma.
Thank you.
So here we are into the bulb. So I want to avoid the possibility to pass through the food because of infection, the risk of infection. In this case, usually we do not perform any antibiotic prophylaxis to perform the biopsy of lymph nodes. We do antibiotic prophylaxis only for cystic lesion and only for the biopsy in the perirectum. In this case, I think that due to the fact that there is a lot of food into the stomach, we are into the bulb now, into the duodenum, but I think that probably prophylactic antibiotic could help us to prevent.
It's certainly, it won't harm her, and it may help her, but it probably suspect.
Yeah, I don't know if it's going to be helpful, but I think I feel comfortable if I'm going to perform the biopsy.
Sometimes we must treat the patient, or the physician, not just the patient.
So, in this case, what we can do as well is to look if we have any pattern of this lymph node which can, show us the tissue characters of these lymph nodes. So I put the power Doppler, but yeah. Oh yeah, I have already asked about the HCV infection in this young lady, and they told me that there is no HCV. I agree with you, because sometimes when you have a HCV patient, we have big lymph nodes at the hilum, but usually those lymph nodes has an appearance of you know, inflammatory lymph nodes, so the endosonographic characters are very well. So it's ovoid, you have a clear hyperechoic central hilum, you have a clear vascular pattern inside with the vessels inside. So I agree with you that this could be an option, and I agree with you on the fact that sometimes HCV patient with lymph nodes can develop lymphoma on these lymph nodes. So I agree with you that HCV infection has to be considered.
Oh, and all that applies to hepatitis B virus as well, I think, to a similar degree.
Yeah, I agree with you.
Okay, so we're going to biopsy here.
So I think that we can biopsy this lymph node. And if
Hello,
see,
can you hear us?
We can hear you, yes.
yeah,
Can we ask you some questions whilst
may.
you're having
Yes,
this
please.
discussion? We found in our experience in our center that the positive predictive value of using the echo characteristics are very poor
Yeah, I
in
agree.
predicting, distinguishing between TB and lymphoma and sarcoidosis. We have a lot of sarcoidosis as well. And there's very poor correlation between the echo characteristics. Is your experience different? Can you predict what the cytology is going to be like?
In my experience, I unfortunately have not such a big experience in TB, because in Italy and in Europe TB is not so frequent. I've been abroad working several times, and in my experience, all the times that I had to perform a biopsy in a lymph node, typical lymph node for TB, has pattern like this. Sometimes, in particular, when the lymph nodes are so big, if the lymph nodes are so big, the pattern is very typical. Sarcoidosis, I agree with you, because inflammatory lymph node and sarcoidotic lymph node are very similar.
Yeah, I would agree. I think that the morphology is not particularly telling, but fine needle aspiration has a fairly high accuracy for tuberculosis, lymphoma. It is more disappointing for sarcoidosis, I think.
Yeah, I agree with you. And if I show you, here is the elastography of this lymph node, and you see that the pattern, the elastographic pattern of this lymph node is fairly blue, so it's a rigid lymph node. This is not the type of inflammatory lymph node. So I think that this lymph node has a malignant pattern, endosonographic pattern, comparing to elastography. So
What we found is the aspirates, the appearances of the
oh,
aspirates.
this is a good. The question is if I have experience in parasitic infection. Oh, can you please remove the stylet?
And so, just for a moment,
yeah.
now you had a question from the hotel?
Yes, we were just wondering if the macroscopic appearances of the aspirate would be helpful in telling you whether this is a caseating necrotic node or whether this is inflammatory or neoplastic.
Yeah, this could be. Sometimes when you do the biopsy, you have caseosis into the core, so you can do the diagnosis only at the first site. So it could be.
I think it's worth it this time to allow Paolo to discuss some of the very nuanced details of how he's going to perform this FNA, because he's taught me some new things out in the hallway. So
First of all, I want to do, in this case, for the lymph nodes, I prefer to use a 19-gauge needle because of the possibility to obtain a core for the diagnosis. So I think that everybody that is using the fine needle aspiration knows that the 19-gauge needle is very hard to be used because of its stiffness. What we do in our department is usually to remove the stylet, because the stiffer part of the needle is the stylet. So we remove the stylet because it just talk to our pathologist in the case, so he or she has to know that we are passing by the gut wall, so sometimes it could have gut cells inside the specimen. So I can put the needle in, and You see here that the outer sheet is on the 0 position. In this case, I can go clearly without harming. You see is at 0. This is very important because I can adjust the outer sheet when I am inside the working channel. So I can fix my needle to the working channel easily, and I find the right position. I can avoid this. I can fix my.
So what's important here is that he's in the second portion of the duodenum, and by taking the stylet out, the needle is not so stiff that it pushes the endoscope out, which is often a real challenge in biopsying from this location. So I think it's a really critical teaching point that can be of high value.
So I can fix the outer sheet in the right position. So I can move my needle. You see the movement of the needles are very easy now. Can you please hold this? No, don't worry, she's great, I think. So I can. Okay, you see the needle tip here.
Yes, we can.
It's a fairly
hard
node, yeah.
Yeah.
And here's the tip. You can see the movement there. It tips right in just the lateral to the center of the lymph node.
We can go back and do. Oh, okay.
That's
now it's better. So the other thing that I usually prefer to do in this case, because I need to have core, so I do like for the liver biopsy. So I go in with my 19 gauge needle. I am deep inside the lesion, so now I can apply the preloaded syringe. Okay, now we can open, and now I can go back gently to have the core inside the needle. So we are. I close.
That's very nice. And so you apply the vacuum. Once you're deep in the needle, you withdraw, but remain inside. Of the,
then I close the vacuum to avoid.
This way you avoid bringing more debris into the syringe.
And then I'm out.
That's a very nice technique.
You only do it once.
Pardon?
You only do it once, and you don't shimmy forward.
No, because we are using a big needle. So, and you know that the lymph nodes usually are very bloody. So if I go on and through and out with the lymph node, the blood is what I usually find. So if I want to have cells, if I want to have a core, usually I do like this with the 19 gauge, and in the second, you can flush. Can we flush the first on one slide to, and probably then the very first. And sorry, I was explaining you. And if you want to do the biopsy with the 22 gauge needle, in this case, I go in and out. But
it's pancreas. It's a cystic area. So we have managed to get inside the duct, and what we are doing is we are deep inside. We are injecting some contrast, and you'll see that it's a cystic space that we are going to inject contrast. If you are getting the fluoroscopy picture, you will see that we are getting a very cystic area there. Dr. Kelgo actually is assisting me by twisting the scope in such a way that we have been able to get inside, deep inside. And you can see that the huge dilated area. Now what I'm planning is that I'll do a sphincterotomy here, put a nasocystic tube to drain the cyst completely, and then I think we'll have to probably go in to do another day to actually drain the other system. Yeah, keep injecting. Can you see the fluoroscopy picture?
This could be very easily.
Yeah, you can see a cystic, large dilated duct also. We are actually, then it's going into cystic space there. So the anatomy is not too clear, but once we drain this completely, I think the patient will settle down. The other option is to put a stent into this area and then do a cut on the stent and go into the second ductal system, the biliary system. But I think this would generally get blocked very rapidly. So these are the two options. So we'll also ask the panel, what is your opinion on this? What do you think? Should we put a nasocystic tube and then come out and then later plan for draining the other system, or should we, you want us to put a stent and then cut on that?
Dr. Reddy?
Yeah.
We need to see the picture of the screen in a good position.
Oh, you're not able to see the picture?
X-ray.
X-ray?
Is it X-ray?
The fluoroscopy is not very clear from here.
Can you push the wire inside?
X-rays are not very clear.
Can we see the tip of the endoscope? Please?
Tip of the endoscope.
Yeah. And to put it in the normal, no, the other way. Yeah. Yes. Okay.
You can see, yeah, I think your picture clarity is not very clear there.
Would you like 6 or 7?
Six. Yeah.
What's the size of the cyst?
We are not able to hear you. I can't hear anything here.
Can you hear us?
Yeah, now it's better.
Okay. Now, so if we think this, the CA99 is in the several thousand, you said it's very high.
CA99 was high.
It's very high.
Yeah.
Then your index of suspicion that this is a neoplastic cyst is high, isn't it?
No, I don't think because CA99 can be very high even in cholangitis. When somebody has an obstruction, CA99 is very non-specific. So that's not a...
We don't measure the CA99, to be honest, because we find it completely unhelpful. But you said the CEA was high as well.
No. CEA in the fluid was not high. The fluid CEA was not done. Only the cytology was done, which was negative for malignancy. The CEA of the fluid would have been a very good guide because that's likely to be more often positive in malignancy, but that was not done. Only the cytology was done, and that was strongly positive. So for inflammatory cells, not malignant cells.
Right. So if this is non-neoplastic, then we're aiming for drainage, for cyst drainage.
Exactly. I think I would assume that this was non-neoplastic based on the clinical history and other things. And I think if we can drain this cyst through whatever means, transpapillary or transmural, then this patient will have very good symptomatic relief. And that's the philosophy that we're thinking. Because if you look at the ERCP picture here, it's a very large cyst which is very freely communicating with a dilated duct, markedly dilated duct. And there's a lot of pus which is there in the fluid. And can you see the endoscopy picture, the pus which is already coming out? Can you see that?
Yes, we can.
Yeah. So I think if you drain this cyst completely, this patient will have fairly dramatic relief, and even the obstruction to both ductal systems will go off completely.
My personal approach in this case would be to stent the pancreatic duct, do a pancreatic papillotomy, and then separately drain the cyst, either transgastrically or transduodenally. You're approaching it twice, in two different ways.
Yeah, you can do that, but I think the problem is going to be that stenting the pancreatic duct is not going to help so much because the stent will get blocked with so much of very thick material. So I would think that the pancreatic duct once you put a nasocystic tube, is going to drain both the duct and the cyst, and we can irrigate this with saline solution and antibiotics to completely clear it off. But we could put a stent and a transcystic tube also.
What does the rest of the panel think, and what does the audience think?
Yeah.
Stent, hands up for a
towards
hands up for those who believe that we should be stenting the pancreatic tree alone.
Nasocystic is the best.
Yeah.
Towards
and hands up.
Nasobiliary.
We should place a nasocystic drain through the main ampulla.
Yeah.
More and more pus here.
Dr. Reddy, is the cyst continuous with the pancreatic duct or not?
I'm not able to hear you. Can you be a little louder, please?
Is the cyst continuous with the pancreatic duct?
Yes. Exactly. The cyst is continuous with the pancreatic duct. In fact, it's like a large cyst which is almost draining completely from the pancreatic duct. Very large duct that you see here.
I think the actual better thing is once you drain this and put a stent, you do another ultrasound, and if the cysts are getting decreased in size, then you don't need to do the puncture of the cyst.
I agree with you. I think you're absolutely right. I agree with you. That's what we're also thinking. See how the pus is coming out? Can you see this dramatic towards, can you flex? Large amount of pus that's coming out from this area. And I think once we drain this completely, the patient will have very good relief. We may not have to do anything at all. We are doing a sphincterotomy which is directed, and I'm using an endocut here with an autotome so that I can direct it at a specific direction. I'm sucking out all the fluid that's coming out. It's very mucky fluid. In fact, our view is getting completely obscured because of this fluid. And I'm now going to
I think with the
put it, yeah.
we'll achieve a lot of drainage.
Yeah, already we achieved a lot of drainage. We'll put in a nasocystic tube. Can you?
That helps with flushing and things like that, isn't it?
I think. Can you remove this? We'll put the wire in place. Wire in place. Can you see this now? So I'm going to now change to a cysto. Push the wire. Push. I'll take it out. Is this okay? You are able to push? Resistance is there? Yeah?
Yeah, so you've cut along the 2 o'clock margin.
Along 2 o'clock margin, and we got a lot of fluid which was coming out, which was very thick, and we decided that it's a thick pus-like material which is brownish in nature. So we are now going to put a nasocystic tube into this area, and I think it will have a fairly good dramatic. I think you have to, Kale is going to slip out a little.
Okay.
Sorry.
Okay.
So that Kale is helping me here. You can see white flakish material also coming out on the screen. This is an indication often of chronic pancreatitis fluid this has this appearance. Are you seeing that on the endoscopy screen?
We can. Yes, we can, Naji. Pancreatic necrosis.
Exactly. I think you're right. The question is whether we have...
Naji, question from the audience. What is the advantage of the nasocystic tube over just placing a simple large bore stent?
I think a simple large bore stent won't help in this case because it will get blocked within 24 hours.
With the pancreatic papillotomy?
Even with the pancreatic papillotomy, it will get blocked because it's a very thick fluid here. It's not going to last very long.
Drain, you'll be infusing the cyst with regular saline. What's your protocol for a nasocystic drain?
Yeah, so once you put a nasocystic drain, we'll infuse the cyst with 200 cc of saline at a time, 6-hourly, with an antibiotic in the saline. There's no evidence from the literature that using an antibiotic in the drainage fluid helps, but we often do that, and we find that helps. We irrigate it every 4 to 6 hours with 200 cc, and that drains off the fluid.
Would you put antibiotics in the...
Yeah, the antibiotics, we generally add an antibiotic in the drainage fluid, but I'm not sure how that's going to help.
Naji, have you sent some of the fluid off for microbiology?
We will take it from the nasocystic tube because that's easier then. We'll send it for microbiology, cytology, get the CA levels done, everything. Although I'm fairly sure now from the fluid, the way it looks, that it's only inflammatory fluid. But we'll send for everything. So we are now setting up a nasocystic tube, and maybe the camera can focus on this tube. The wire here, camera can focus outside. Can you focus on the assistants? No.
We can't see the tube. Can we see the tube?
I'm sorry, I think camera will have to focus a little more.
And what size nasocystic tube are you going to use?
Can you, I'll just show you as the tube comes into the view, because the camera here, the position, you can't actually get a good position.
What size, Naji? What
size? Can you see that now? This is 7 French. And I'm going to get it in through. We can, in addition, put a stent, but I don't think that will help too much because of the sphincterotomy. We are not able to hear from there.
Yes? Naji, this is a pigtail stent, so it has a pigtail at one end and straight at the other end.
Exactly. It's a pigtail at one end so that it stays in the lumen. And you can see it now coming out endoscopically. And we'll also check fluoroscopically. You have to gently pull on that, gently pull on the wire, gently pull on the wire, and fluoroscopically check. Pull on the wire, pull on the wire. You can see the stent going in now. Pull on the wire, pull on the wire. Pull, pull, pull. Pull on the wire little, pull on the wire. It's okay, it's a fluoroscopy. Pull on the wire. You're not able to get it? No, pull on the... So can you see the... No, just wait, stop. So that we'll have to get it in deeper now little. So I'm going to get my scope out a little more. Yeah, now we are in a better position. You have to keep pulling a little as you...
The angle.
Pull. Yeah, pull. Fluoro. You see the thing deep? Yeah. Can you see it deep inside? Huh? Yeah, I'm trying to get into cystic lesion. I think we'll be able to get in, no problem. Fluoroscopically, can you see the tip now? Can you go up? Can you see it up there? It's gone up. It's gone to the upside.
Can't see it clearly. Where's the tip now?
Yeah, the tip is just at the scope, at the site of the scope, in the cystic cavity. But I think your fluoroscopic image, they may not be good enough there to see it now.
Can we magnify this?
So the aim is to get the end of the nasocystic tube as far in as you can. Yeah.
Exactly. As far as possible. So that's what I'm doing. As the assistant here is pulling on the wire, she's pulling on the wire and I'm pushing the tube. So it's progressing slowly in.
So the assistant is applying tension on the wire and you're advancing over the wire.
Exactly. So she's pulling on the wire or tension on the wire and I'm sort of pushing this tube. I think we have gone in fairly okay. Although I want it a little more longer. Can you pull? Yeah, pull.
Yes.
Can we see the fluoro, please?
No?
Hello everybody, good afternoon, guten Abend. Now we are going to discuss a case of EUS. This is a male patient, 44 years old. He was presented with recent onset of jaundice and was diagnosed as having obstructive jaundice. He has, with low down obstruction, he has ERCP, and ERCP revealed a prominent papilla, and stent was inserted with marked improvement. However, the endoscopist said that the papilla is prominent and he's suspecting that there is a pathology in the papilla. So now we are doing EUS for him to make sure that there is no pathology in the papilla with Professor Paulo. Thank you.